afternoon to everyone and a very welcome. It gives me a great pleasure to inform everyone that Voice of Healthcare has taken an initiative to mark this ongoing international drive of Breast Cancer Awareness Month. We'll be conducting a month long campaign of discussions and interviews where our expert panelists share their views on the best practices to manage and curb breast cancer. This panel's discussion is organized by VOH in collaboration with Zydus Cadila, and the topic of this panel is Detect to Protect, Every Women's Guide to Know Signs, Symptoms, and Treatment Options. Our panelists are as follows. Dr. R. Ranga Rao, sir, is the chairman of Paras Cancer Center at Paras Hospitals, Gurugram. He's yet to join us in a couple of minutes. Dr. Ullas Batra, sir, is the senior consultant and chief of thoracic medical oncology at Rajiv Gandhi Cancer Institute and Research Center, New Delhi. Dr. Sham Agarwal, sir, is the chairman and director of Department on Oncology, Sir Gangaram Hospital, Delhi. Sir is again yet to join us in a couple of minutes. Dr. Amit Agarwal, sir, is the professor and HOD at Department of Endocrine Surgery, SGPGIMS, Lucknow. Ms. Vandana Gupta, ma'am, is the founder of VCare Foundation. I'm sorry. And Dr. Asta Dayal, ma'am, is the lead consultant gynecology at CK Birla Hospital, Gurugram. Along with sharing her expert views, Dr. Asta will also be moderating this session. And without any further delay, I'll just hand it over to ma'am, Dr. Asta, and she'll just begin with the discussion. It's over to you, Dr. Asta. Thank you.
Thank you so much, Khushbu, for organizing this session. And as we all know, October is the Breast Cancer Awareness Month, and it's a good opportunity for all of us to learn about breast cancer. And breast cancer is actually the most common female cancer all over the world, and it actually represents a quarter of all the cancers of women. And the global burden has been increasing worldwide. According to WHO statistics, about 1.3 million new cases of cancer are detected every year, and there are more than 4 lakh deaths. And from this global burden, the proportion from developing countries like India has also been increasing steadily. So I would like to start my discussion with Dr. Ullas Batra. I would like to ask you, sir, about the breast cancer incidence in India and why there is this about 3 to 4 fold variation between the rural and the urban population, and what is the reason for this increasing incidence in a developing country like ours?
Thank you, Dr. Asta. And I think you quoted some very scary figures actually. 1.3 million cases of breast cancer, and just compare it with what COVID had. When COVID had, and it was declared a pandemic way back in March 2020, we had hardly any cases. The entire country went into a lockdown when we had only some 30-40 cases. And here is a breast cancer here, and here is a cancer which we have done so much of research upon, and nobody speaks a word, nobody's really bothered. And that is why I really want to congratulate VOH and everybody in the panel who have taken up the subject. And for me, I am coming to your question, but for me, I'm very put off by this fact that October is a breast cancer awareness month. I think every day should be a breast cancer awareness day. Every month should be a breast cancer awareness month. Now, coming to your question, 1 in 29 people will actually, women will actually develop breast cancer in India. So just imagine, are there 30 ladies that you know of? Yes, we know of. 1 in 29 ladies will get breast cancer if they live up to the age of 80 or 70 years of age. That's again very scary. The number in the US stands in 1 in 9, 1 in 8, or 1 in 12. Why is that so? Again, there are some controllable factors, there are some uncontrollable factors. The uncontrollable factor, you can't control your menarche, you can't control your menopause, you can't control your family history. But what you can control is your physical activity. What you can control is whether you want to take a lot of OC pills. What you can control is obesity. What you can control is your exercise. What you can control is, so anything which increases the estrogen exposure in a woman's body gets the patient to a slightly higher chance of getting a breast cancer. Having said that, I am not saying that nobody should take OC pills. The moment I say this, they will say OC pill nahi lena chahiye. ऐसा नहीं है, लेना चाहिए, अनकंट्रोल नहीं लेना चाहिए, अनरेगुलेटेड नहीं लेना चाहिए, एक डॉक्टर की सुपरविजन में जो है वो लेना चाहिए. So, why is the incidence of breast cancer increasing in the urban time? One is because of all the westernization of the of all our Indian cities. You know, your food habits, your lack of exercise, your obesity, delayed childbirth more than 35, 40 years of age. That is one of the reasons. One of also the reasons which I would say is probably a better detection also, a better awareness also. So what also happens in rural India is people are not even aware of all these things. So maybe because in metro cities you have more opportunities available, more methods of detection available, the doctors, the nursing homes have got things available. That is why also it detects. So that is the reason why you have got a more incidence of breast cancer in the urban population. Back to you,
Uh,
Dr. Asta.
Thank you, sir. So, I would say that for the oral contraceptive pills, most of my patients are actually very scared of the pills. I have to tell them that it's safe to take it temporarily. But yeah, as you rightly said, the lifestyle factors, the alcohol, smoking, all those things are contributing. And I think in India, we also have a little younger age group getting detected with breast cancer as compared to the rest of the world. I don't know why, but yeah. So yeah, so
So the
as
answer is, I'll answer you that, Dr.
yeah,
Asta.
yeah, yeah.
In India, a very pertinent point that you have made. In West, the age at which breast cancer is detected is 50 to 60 years of age. In India, it is actually at 40 to 50 years of age, and the younger you have, the more aggressive kind of a ERPR negative and a triple negative breast cancer also is there. So it's almost like saying everybody's cancer is different. We are different from our Western colleagues. We are very different from our Asian colleagues. So breast cancer also is not a single disease. The guidelines which are there for the West are not suited for the guidelines which are there in India. And you're absolutely right that the incidence of cancer in India is slightly younger, is in the younger population, and a more aggressive TNBC kind of physiology in those subgroups.
Thank you, sir. So, as you mentioned, that there's no sure way to prevent a cancer, and there are a lot of non-modifiable risk factors. So I would like to ask Dr. Sham Agarwal, welcome, sir. Sorry, Dr. Amit Agarwal, Professor Amit Agarwal. What are the risk factors associated with breast cancer?
Thank you, Dr. Asta. At the outset, I must congratulate VOH and especially for the title "Detect to Protect." So it's a very apt title for the talk and increasing the awareness of breast cancer. I think Dr. Batra hit the nail on the head when he said that it should be every moment and every day should be an awareness month. As far as risk factors, Dr. Batra already shed light on that. So we have some modifiable factors and some non-modifiable factors and some genetic factors. But factors like use of alcohol, physical exercise, these are modifiable factors, and it's very important that we avoid alcohol use and build our physical regime in our day-to-day practice. That is very important. Other factors are like greater parity, then age and menarche. Of course, these are non-modifiable factors. The family history is a very important factor. It's a very strong association with breast cancer. So any lady who has a family history of breast and ovarian cancer, especially on the maternal side, Mausi mein, Nani mein, sisters, it is extremely, extremely important. I've been practicing breast surgery for the last 25 years. And we make it a point that when a patient is treated, we do a proper counseling and ask about the sisters and their relatives, first degree relatives. So that's extremely essential. The more important than OCT is the use of HRT. And as a gynecologist, you would concur with me that HRT, especially the combination of progesterone and estrogen, does confer an increased susceptibility to breast cancer. Of course, once you stop it, the propensity decreases. So that's all right. So I think one should start with the minimum dose of HRT, and I'm sure all ladies who want to take HRT have to have a proper mammography done before you start HRT, and the minimum dose is started. Besides these factors, there are some breast diseases also. For example, if you have a lump and it is turned out to be an atypia, it confers a four increase of breast cancer. So there are some breast diseases like lobular carcinoma in situ. So I mean, for a layman, it's important that if you have a lump in the breast, it should be properly treated surgically, and appropriate action to be taken. So if it is of worrisome like an ATPR, then you should keep a close follow with the doctor. That's very important. 10% of breast cancers are genetic predisposition, and they have some important genes like the BRCA1, BRCA2, P53, which confer increased susceptibility. And for ladies who have these genes, there is a 50 to 70% risk of having a breast cancer by the age of 70 in their lifetime. So this is a very important, and fortunately in India, these tests are now available. They were very costly at one time, and now they are not so costly. And as physicians, it is imperative that we offer genetic testing in patients who have family history and who have certain types of cancers where we know that they are likely to have this mutation. So it is the responsibility of both the physicians as well as the patients to be aware of what kind of testing needs to be done. But certainly in India, the incidence has increased definitely, and it is to more awareness, due to more detection, and due to change in lifestyle towards more Western lifestyle. But these are some factors are really modifiable, and we should really pay attention to these factors. Over to you.
Thank you, sir. Thank you for this insightful information. And so now I would also like to know about the various signs and symptoms, the clinical presentations of breast cancer according to the various stages. And I would like to ask Dr. Sham Agarwal. Welcome, sir. So I would like to ask you about the clinical presentations.
Yeah, thank you, Dr. Astha, and thank you for this opportunity and invitation. So the symptoms of breast cancer are actually very few. People, don't feel any pain or weight loss or fever. So actually, they feel good. So the only thing which appears first is a lump which is painless, mainly in the breast. But and gradually it tends to increase in size, as I said, without causing any pain. I mean, if the tumor or if the cancer is located in the vicinity of the nipple and areola of the breast, so then they can observe some change in the shape or size, or inversion of the nipple. And some women, because of that location of the tumor in that region, can also have bleeding in the through from the nipple. So any unusual bleeding happening, or any bleeding happening from the nipple, should warrant a lady to sort of go for testing. So a lump which a lady should pick up maybe during her monthly checkups, which is what she's supposed to do. Any change in the shape of the breast. So if one breast looks different from the other, because a woman knows her body. So if she's looking into the mirror, so I mean, any change in the shape, or if the skin is involved, then you can see some redness there. Some women can have a tumor just underneath the skin. There can be some dimpling there. So very subtle signs, and women need to be sort of educated that examining their breast for these kind of signs. So that will be the first stage for by and large for breast cancer. So as it increases in size and as it tends to spread from lymphatics into the axilla or the armpit, so ladies or women or patients with breast cancer can also observe a lump in the axilla. So a painless lump again, which is gradually increasing. So those are two early signs to my mind. I mean, the armpit is of course happening at a later stage. And then, of course, there are patients where the disease is picked up in advanced stages, when the disease has possibly gone to various organs, such as bones, and patients can present with pain in any bone, like backache, or in the pelvic area, or in the legs, femur, or in the humerus or in the upper arm. So, bone pain is another symptom which can happen as a first presenting symptom, and then you start investigating and you find that this patient actually is having a breast primary. If somebody has a tumor gone into the lungs, well, then they can have cough and hemoptysis, which is blood in the sputum. And if the patients have disease in the liver, then they can have weight loss and loss of appetite, not wanting to eat, fever. So those are symptoms related to advanced stage. And if it goes to the brain, then they can have headache or nausea, vomiting, chakkarana. So those are the symptoms. But I think we need to educate women for detecting or picking up early cancer in the breast by way of examining for the lumps and looking at any kind of change in the shape or bleeding from the nipple. Yeah.
Thank you, sir. So, as you rightly said, that early detection is actually going to go a long way in reducing the mortality. And unfortunately, in India, because we don't have that level of awareness, the mortality rates are disproportionately higher in our country. And also, there is limited access to information, to diagnostics and referrals. So I would like to ask all of you about the importance of early detection and the role that corporate hospitals and government hospitals can play with it in this. So, fortunately, we have doctors from corporate as well as government hospitals. I would like you to take Dr. Amit, and then Dr. Ulas, and then Dr. Agarwal can also answer this question.
I think,
So,
Dr. Amit, sir, I will
yes,
answer on the importance of early detection, and then you and Dr. Sham can take the government and the private sector questions. Sir. Is that okay,
sure.
sir?
Yeah, that's
I'll
fine.
take the easier. So, why should we detect them early? I'll give you a very simple statistics. Stage one breast cancer, you have a survival of 95%. Stage 1 breast cancer, you may not require chemotherapy. Stage 1 breast cancer, you may not require a mastectomy. Stage 1 breast cancer, the scar might just be very, very minimal. Compare this with stage 3 or stage 2 breast cancer, your survival rates are 60%. You will definitely need chemotherapy. You may end up with an MRM, or the scar is more. Come on, it doesn't take a doctor or a VOH or anyone to find out that early breast cancer is the time to detect the breast cancer. The scientific reason for this is, if you have, I'll just give a very normal example to the people. Let us say I have to fight with one person, it is easier, right? If I have to fight with 10 people, that's more difficult. If I have to fight with 100 people, that's again more difficult. So when the cancer is small, you have very small cancer, the cancer is localized, the spread to the body is very, very less. So that is why treating early breast cancer, definitely, because you may not need chemotherapy, and that's the biggest incentive to everyone. I say, I'm a medical oncologist, and I tell them, if you want to drive me out of business, please come and get a mammography done, because the chemotherapy is one of the major factors that people actually are bothered about. So stage 1 breast cancer may not need chemotherapy, great survival, definitely BCS, less extensive surgery, very good quality of life, you will not lose your hair. Choice is very, very simple, it's yours. Now to Dr. Amit Agarwal and Sham Agarwal for the more cautions about corporate sector versus government sector. Sir.
So, Dr. Batra, you have covered the importance of this stage very nicely. I'll just add that for the benefit of the layman, the stage 1 breast cancer is when you have less than 2 centimeters, stage 2 when it is 2 to 5 centimeters, and stage 3 when it is more than 5 centimeters, and stage 4 when it has spread in the body. So, if you come in stage 1 and 2, the prognosis is called early breast cancer. The word itself is early breast cancer, and it has fantastic survival and prognosis, Dr. Batra already said. And this is the single most important factor in survival. I have been practicing breast surgery and chemotherapy for last 25 years, and I have hundreds of patients who have survived for 20, 25 years. So you can see the beauty of this. The treatment in India now is fantastic. You have everything available. You have fantastic drugs available. Surgery is no longer mutilating. As Dr. Batra said, you have a breast conservation surgery where your breast is saved. So there are ladies who are playing golf, who are doing their work, who are doing mountaineering, who are cycling despite having a breast cancer which has been treated by surgery, chemotherapy, and radiotherapy. So you have a good quality of life as well. So both the quantity and the quality of life is maintained if you come early. And early you can come only by awareness. Awareness in the society, awareness in the family, awareness by the women herself. That is very important. So everybody in the family, right from children to adults, should be aware and encourage and motivate others. In India, we have a social taboo because of social constraints, because of some social practices, and access to healthcare is also very, very limited. But I think things are changing. As a government, from a government perspective, I must tell you that we treat hundreds of patients who have had the benefit of different government schemes, the Aishman scheme, the Arogya scheme, the Ati Nirdhan scheme, and so our patients are getting a world-class treatment, a Memorial Sloan Kettering treatment in India at the minimal cost, free of cost. They are getting surgery, world class chemotherapy, drugs, all free of cost. And they should take advantage of these government schemes. And I'm very satisfied and happy working in a government sector. I'm able to treat these poor patients who have otherwise would have been dead, and they are now leading a good quality of life. They regularly come for the follow-up. Our follow-up is excellent, more than 60-70%. And they have had the benefit of being treated in a government hospital absolutely free of cost or at a very subsidized rate. So they have this benefit. And the government sector, as the corporate sector, is offering fantastic healthcare, which has a very social aspect also. So it's not only healthcare; it's a social aspect that we are taking care of.
Thank you, sir. And Dr. Sham, please tell us about the treatment and the detection in corporate hospitals with respect to breast cancer.
Yeah, I think they've already said that the ability of our country to detect breast cancer in early stages is still evolving. If you were to look at the Western countries like Europe and US, nearly 80% of those cases are detected in early stages. So, as was pointed out by Ullas, that almost 90% patients will be cured permanently with breast conserving surgery, etc. On the contrary, look at our country. So we have the opposite. Only 70%, patients are, only 20 to 30% patients are being picked up in early stages. So there's a huge gap which needs to be filled up by not only the government sector, the corporate, the NGOs, and so many other organizations really have to take this message clear and loud to not only in the urban areas but also in the rural areas. So I think, as we all know, breast cancer has become the number one cancer in our country. It has, far superseded the cervical cancer, and that's happening because of our, getting into a culture which is similar to what the West is. But we are not following the practices, or we are not able to follow the practices for early detection by way of monthly checkups which the women should do. We have to educate them, or at least 6 monthly they should go after the age of 40 years to a gynecologist or to a surgeon for physical examination. And after the age of 40 years or 50 years they should have a mammogram once in a year or once in at least 2 years. So these are areas which we need to propagate in a huge fashion to come closer to the Western figures. At the moment, I mean, I understand that in the urban places like Delhi, metropolitan cities, we are seeing a fair number of early breast cancer. But I think 80% of the country resides in villages and the rural and the B towns. So where is the awareness? Where are the people who have the facility of doing mammograms every 1 to 2 years after the age of 40 years? So I think there are huge gaps which need to be filled up, and each organization, whether it is corporate, whether it is a charitable institution, whether it is government, whether it is NGO, has a huge responsibility to be filled by way of educating, bringing awareness, and providing the facilities to do these investigations and evaluations to pick up the breast cancer early. And as Dr. Amit said, I mean, there is a taboo. People feel a lump in the breast, they hide it because they're scared. It turns out to be cancer, then you have to go for all that surgery, chemo, radiation. So that scare has to be removed from the minds of the people, and that's only if on a regular basis promote these awareness programs and bring this availability of these newer modalities such as breast conserving, minimal radiation, minimal chemotherapy, etc. So I mean, the protocols have become easier. Earlier radiation was like 5 weeks, 6 weeks, or something like that. Now it has come down to 3 weeks. Breast conservation is a huge bonus for early breast cancer. And similarly, the hormonal therapy, etc., has really become very, very refined now. So I think all these things put together, I think we need to really propagate the awareness amongst women, so that they can come forward for screening of breast cancer and have an early detection, so that minimal treatment can cure them.
Very true, sir. And actually, yeah, even I'm working in a corporate setup. So, but I see there is still very little cancer literacy, despite having educated patients or from good socioeconomic backgrounds. The stigma is still there, and the awareness is very low. And although we have very good facilities in India for treating breast cancer, but early detection is still lacking. And that brings me to my next question, which is from Vandana ji. Since you are the founder of We Care and it's a cancer foundation, I would like to know what role can NGOs play in reaching out to at the grassroots level to people to spread awareness about early detection.
Thank you, Dr. Astha, for asking me this question, and thank you for inviting me for this panel discussion. Uh, I need to start from the very beginning. Like Dr. Agarwal mentioned, that we have a huge population living in the rural areas, about 80%, and we have 20% people living in the urban areas. And as of now, what I feel is that all the training, all the education, all the material that is created for the benefit of the urban ladies. Because whether it's in magazines, whether it is in newspapers, whether, it's all English related and it's all for the urban. But we are not really focusing on the rural areas. And hence that area, which is a large percentage, gets left out. Now, first thing that we need to do is understand the needs of the people in the rural areas and work according to that. So, which brings us to the health literacy part of it. How simple are we delivering the message in? The language that we are using. Is it simple enough for them to understand, or is it still complicated and has a lot of medical jargons in it? So, because they don't understand it. So, if you add on to the medical jargons, it's not going to go down well with them. The second thing is that, as doctor mentioned, that there are a lot of stigmas attached to it. If you have breast cancer, the people might turn you out of the house. They may not like to treat you. We need to focus on the fact that a woman is the fulcrum of the family. Say what you may, but unless the woman runs the house as efficiently as she can, multitasking in the house, that house does not function. With the result, you need to focus on the thing that the woman's health is priority. So, if the woman's health is priority, how do we go about it? What are the things that we need to do? And that is what is important. Fortunately, we have very good ASHA workers working in the rural areas, and I think they can learn a lot and they can convey a lot. So if the government takes up a program, and all of us NGOs, all of us, I'm sure the doctors are willing to support that and train the ASHA workers in how to teach them to do the breast self-examination, because many people cannot afford mammography on a regular basis. So breast self-examination would become the best thing to do. So if they can be taught breast self-examination on a regular basis, I think we will have this problem sorted out, with the knowledge that it's not a stigma to have breast cancer and that it can be treated if detected early. And also, this knowledge has to go to the spouses, to the in-laws, because we all live in a joint family, most of us, and to the children. So the children must understand that their mother's health is important. The husband should understand that the wife's health is important. And what is the most important factor? The breast, which needs to be looked after, which needs to be taken care of. I know that there are lots of programs in the village areas, which are in the rural areas, which are conducted to for pregnant women, which means that all pregnant women from the time of their pregnancy to the time of the delivery are asked to come regularly to the hospitals, and there is a card which is made for them, and everything is registered there, everything is noted down, their health is taken care of. I think, like one the doctor, I think Dr. Agarwal mentioned that from 40 years onwards, we should be careful about it. Why can we not have a similar card made for all the women, and that it becomes almost mandatory for them that they can come every month and get that checkup done, and it is all noted down. So the moment there is a change in something, it is immediately brought to the notice, and it should become like mandatory for. Also, I think that a lot of programs are being done for the by the various organizations, by the various pharma companies, by the various corporate hospitals on breast cancer awareness. But I think these programs are, maybe now because of online people may hear, but many people may not like to know or hear or something like that. So it becomes, like, even if we make it that we sort of broadcast it, that anybody who is coming to the hospital, whether it's a local hospital, whether it's a government hospital, whether it's a corporate hospital, every lady can walk in free for either a mammography or a breast self examination or a test, so that within that month so many people can be covered. We can do it. We've done it for COVID, that everybody has been vaccinated. A large percentage of people have been vaccinated, and the symptoms have been constantly talked about, and people have become aware of it. Similarly, if we can do that at least twice in a year, that every hospital takes on this responsibility, that they can work and they can come walk in the hospital and get their things done, maybe not at a charge for people who cannot afford, because it's going to be a challenge for people to afford the test every time, and that is what comes in the way of the women in the house, in the villages, in the rural areas, in the urban areas. That how can you spend so much money on the health of a woman? We know our insurances are not good enough. We know that it can't be taken care of. As an NGO, I mean, I'm not absolving NGOs of it. The responsibility of the NGO is that, whenever we are meeting any patient, a patient or a woman patient or a child patient, the family accompanies them. And then it is our responsibility to ensure that we talk about breast cancer, we talk about lung cancer, we talk about oral cancer, a cancer which they are not affected by, and we sort of educate them and ensure, or at least try to ensure, that they all go in for a checkup, because most hospitals have a screening provision. So if that can be done, then it would really help in a very big way to bring down the numbers. I'm sure we can all do together, but simplicity in the language, cost effectiveness of the treatment, no stigma attached to the disease are the major things that we must work on before we start doing it. And one more point I want to add on, that in the rural areas, the punch or the sarpanch has a lot of authority. So if we can include the punch or the sarpanch in our program and say that we are doing this because we want the women to be protected, and that if he can help us by saying that every woman in the village must have a breast examination done on a regular basis. I'm sure the men will also, or men of the family will listen to the sarpanch, and it will empower the woman, because then she can go around and say, the sarpanch has told us this, and so we need to do it. And I think that can be done in a very big way, and that is how prevention can be started at a and we can get the cases detected at a very early stage. Thank you.
Thank you so much. In fact, very
Make a
rightly
point,
said.
Dr. Asad.
Sorry, yeah.
Yeah,
Yes, sir.
please you continue. I'll make a point after that.
So I was just saying that yes, as we have promotion for breast cancer, sorry, for lung cancer, like on cigarette packets, tobacco use, there's so much of media coverage, everything. But for breast cancer, I think we're not doing our bit. And breast self examination is a very cost effective way. It's free. It's easy to learn, and all women can do it very easily. Although mammography detects it at a much earlier stage, it is not really a recommended screening way. But in a country like ours, where we are resource deficient, breast self examination should be taught to all the women. Yes, sir.
Yes, regarding screening, I just want to say, and this is for Dr. Ullas and Dr. Agarwal, who are influencers. Mammography screening has been shown to reduce mortality in Western world. There is no doubt about it. Before they had after 50, but now most of the countries now say after 40, the mortality certainly decreases if you do mammography screening. It's very unfortunate in India, at least the urban population which can afford a mammography, they are unaware that mammography screening should be done. And I get ladies from the elite class, and I'm really surprised that they have not heard that mammography. They said, "Humko kisi ne bataya nahi, nobody told us." So at least that population should be covered by mammography screening, and we should perpetuate and propagate for the urban class. Now, having said that, coming back to the rural class, now we have different government schemes, and I think our influencers should discuss with the government that it can be incorporated as a part of the different schemes, mandatory mammography screening, at least after the age of 40 in India. Uh, that's one point. The second point I'd like to make is now there are different types of screenings available, and the NGOs can. This is for Mrs. Vandana Gupta. That besides mammography, you have thermography available. You have different type of ultrasounds available. I've even heard that there are certain bras which are lined by ultrasound. And the person has a mobile with him, gives the bra to the lady who can go inside and wear it, and he can have the image on the mobile. So this is the way to overcome these social taboos. You have to go to the homes and make the women comfortable. They may not come to the hospital, but you can use different techniques of screening, which are sort of customized for our own rural population. So I think NGOs and different sectors can take a lead in this to develop the indigenous ways of the screening programs for the rural population. Thank you.
Thank you, sir. So that actually brings me to my next round of questions, and I would again address this to Dr. Amit Agarwal. Like, sir, you mentioned about the different screening guidelines, and there is a lot of variation in. Like, I see women, and it's very easy to tell them that cervical cancer guidelines are exactly universal. So every 3 years you do a pap smear, or every 5 years a pap and HPV. But in terms of breast cancer, every country has different guidelines, and depending on the risk factors, depending on the availability of resources, the UK says you can screen after 50 every 3 years. America says you should screen every year. So, what kind of screening guidelines should we have in India? Since we already know that the population here is also a little younger who have breast cancer. So, what are the general guidelines that you recommend? Professor Amit Agarwal, so this question is for
Yeah,
you.
uh, I don't know whether it requires a lot of brainstorming because India is a vast country. There's a lot of heterogeneity. So having a uniform policy is a Herculean task. But having said that, as I said, we have to evolve cheaper methods of screening. And unlike America, every year would be a difficult proposition in India. So maybe every 3 years, or you have to have a midway every 2 years. That would be sort of ideal for our population. But besides mammography, we have to have a multitude of screening methods. One screening method perhaps cannot be applicable across the vast country like ours. So I think we have to have some different methods for rural population as compared to the urban population. Mammography screening once every 2 years, at starting from the age of 40, definitely. And maybe if there's a family history a bit earlier, for those people. And for rural population, and ultrasound screening or thermography, this kind of things. But I must say, it should be made mandatory for those patients attending hospital. So we have a captive population which is attending the hospital, the government hospital or the corporate hospital. And if we can, capture that population for a mandatory mammography screening, that would be really helpful.
Yeah. Thank you, sir. So, we also know that about 5 to 10% of breast cancer is hereditary or genetic. So, I would like to ask Dr. Ulas Batra, what do you think is the role of genetic screening in breast cancer now that it is available in India and it's affordable? So, what is your take on that?
So I think genetic screening is very, very important. But I would again want to add a cliche onto that, genetic screening in the right hands for the right people, and after providing pre and post counseling. It is very easy in India, we are a democratic country, to ask for a test. And then what happens after the test is the most important issue. Let us say so first of all, there are three components which I always say are very essential for a screening. First of all, let's say you have a lady whose mother was diagnosed with breast cancer at the age of 80 years, ERPR positive, HER2 negative. The lady is 35 now, her daughter. You do not need a mandatory genetic screening for that lady. Very, very important. If you, on the other hand, have a lady who has been diagnosed as triple negative breast cancer at any age, or you have a history of male breast cancer in the family, or you have a history of bilateral CA breast in the family, or you have a history of young CA breast in the family, these are the people whose kith and kin should actually undergo genetic screening. Why is it important? Obviously, if you have a gene in the family, you would want to catch them young, your sisters, your children. And if you catch them young, you can do a screening for them, you can put them under aggressive surveillance, and then you can, the typical Angelina Jolie Joe effect of BRCA1 BRCA testing can be done. But important thing is, you should always do a counseling for the patients who are about to undergo a BRCA1 and BRCA testing. Dr. Asta, now BRCA has become so easily available that every Tom, Dick, and Harry, now people come to us with a report that, listen, my chacha ka tau ka beta had a cancer. I went to that fala lab and now I have this report. Now you tell me what to do. I asked them, did you go to oncologist? No. Did you go to a genetic counselor? No. Who asked? He asked and I got it done. So pre and post genetic counseling is the most important thing. Let us not reduce genetic counseling to a farce, because the more number of laboratories coming up, the more number of uncertain VUS coming up over there is going to really,
I think we
is
have a
really going to take
network
the shine out
glitch.
of the is really going to take the shine out of the one. So I think genetic counseling, yes, but only in selected patients. You need to have. Can you hear me?
Should we wait?
Yes, yes,
Yeah,
we
I
can hear you.
can hear you.
Okay. So
I think
genetic counseling in a patient. So again, in breast cancer, any patient with a triple negative breast cancer, anybody with a history of male breast cancer, anybody with a history of breast cancer and ovarian cancer in the same family, anybody with a young breast cancer, definitely go for a genetic counseling. But please go ahead and do a pre-counseling, pre-genetic screening test, because otherwise, all the oncologists and all the genetic counselors are going to land up in soup. Back to you,
so.
Dr. Asta.
Sir, do you generally advise a genetic test for all the young women who
Yes,
end up with the
yes, we
cancer?
do. Yes,
And
we do.
what all options do we have? Only BRCA testing or other kinds of?
No. So we start basically with BRCA1, BRCA2 testing. Now there are two ways of doing things. One is germline, one is somatic. Germline is one which is done through the blood, and basically which means that all cells in the body will have, and otherwise you go to BRCA1, the somatic one. If that is negative and you have a very high index of suspicion still, then you have full NGS panel in which you can do the testing. So again, this has to be assessed by your oncologist and by your genetic counselor whether you really need the test or not. Now I'll just give an example, just in case my family history is not very significant and I get a gene, ATP gene which comes over here with significance I don't know. Now I'll have a sword on my on my neck all the time. What do you do with that? So I should be very willingly going into the test, and again the testing should be done for the index case first. Only if the index case comes positive, then you go to the kin of the person.
True. Thank you, sir. So now let's talk about the different treatment options, the surgical, the chemo, radiation that are available with us, and what are the expected outcomes. So I'd like to ask Dr. Batra again about the treatment options that we have.
So I think Professor Amit will speak about the surgical options. I can tell you about the most Dharamna option, that is the chemotherapy. So first of all, not every woman with breast cancer needs chemotherapy. Let us be very clear about it. The more ER/PR positive you are, the more elderly you are, the less benefit you will derive from chemotherapy. Now, chemotherapy is like a bomb, chemotherapy kills the good cells, chemotherapy kills the bad cells. So when the bad cells get killed, you are happy, but also chemotherapy leads to a bit of complications such as hair loss. 5% of people can have nausea, vomiting, some mouth ulcers, and all. It is very important to remember that all these side effects are temporary. You look at Manisha Koirala, you look at all the everyone who has undergone chemotherapy, and Sonali Benzi, they all have got beautiful hair back. So all the side effects which will come will not occur in 100% of people. They will occur only in 5 to 10% of people, and they are temporary, they are reversible. And the chemotherapy will only go for probably 4 months. And the advantage that it gives you is probably, even in a triple negative or a high node positive, is around 20 to 30%. That means your chances of getting the cancer back reduces by 20 to 30% if you actually take the chemotherapy. Having said that, not all people require chemotherapy. If you are a node negative, ERPR positive patient, the benefit of chemotherapy is minimal. And there are a lot of new genetic tests which are there, which are oncotype, mamma print, other tests which are there, which will exactly tell you about what is the exact advantage of chemotherapy. In addition to chemotherapy, you have oral hormonal pills. You have if you are ERPR positive, you can be given tamoxifen or anastrozole or letrozole kind of a tablets. These tablets are the ones which will, if you are ERPR positive, which will probably reduce your chances of getting cancer back by even more than what chemotherapy does. These tablets, simple tablets, have to be taken for around 10 years. In addition to this, so I spoke about chemotherapy, we spoke about hormone therapy. You have targeted therapy. So there is a gene in your in the breast cancer called the HER2 gene. If your gene is amplified, and again, please mark my words very carefully, if your gene is amplified, not everybody gets the gene amplified, only 20% of the people will have a HER2 amplification, then you have drugs such as trastuzumab and pertuzumab, which can just change the course of your life, and your life survival can increase to lots. Definitely in early stages, in stage 1, 2, 3, we talk about curing you. In stage 4, we talk about increasing your life survival with a good quality of life. In fact, I will just like to remind everybody to read Emperor of All Melodies by Siddharth Mukherjee. In that, he has quoted a sentence. In 1987, when trastuzumab was being launched in a clinical trial, one lady who had no options available fought with the US government to give her trastuzumab. She had no options. She was just given hardly 2 to 3 months to live. That lady, who was the first patient to get trastuzumab, lived for 20 more years after that. Such is the power of this target therapy, this hormone therapy, and the chemotherapy, that we have got people out from a very distressful situations into a absolutely fantastic quality and quantity of life. I again say, I take the death of every breast cancer patient very personally. I don't think, I think in 20, 30 years of time, we should come to a state that everybody, breast cancer should be as chronic a disease as a diabetes and hypertension and asthma should be. People should not die of breast cancer. They should live and defeat breast cancer. Dr. Amit, to you now, sir, for surgical questions.
Yes, thank you, Dr. Ulas. I think a couple of points before I come to the actual treatment. The breast cancer is like a time bomb, and there is a bomb squad which is made up of the breast or an endocrine surgeon, the medical oncologist, and your radiotherapist. These three work together to defuse that bomb. And I'm very happy that in India, the treatment of breast cancer is now very, very standardized. So this is for the patients, that you should not feel afraid. The breast cancer is very well treatable, and very well standardized treatment is there. The chemotherapy part has already been covered. Surgery, I must tell for the patients that there are two types of surgeries. If you come early breast cancer, we can offer you breast preserving surgery or breast conserving surgery, where only the tumor and a part of the normal tissue is removed, and your breast shape and size to a certain extent is maintained. If you come in stage 3, then we can give chemotherapy and then do a breast conserving surgery. So surgery has become non-mutilating, and it has become very aesthetic. The second part is that even reconstruction can be done. Even after the breast conserving surgery is done, तो एक जो डिम्पल पड़ जाता है या जो गड्ढा पड़ जाएगा, उसके लिए भी एक reconstruction is possible, and patients can go away with almost a normal breast, and one can hardly say that the patient has undergone a surgery for breast cancer. So that how far that surgery has become aesthetic. Even if your breast has been removed, then there are reconstruction options like an artificial breast implant, or we take some skin and muscle from your own body and make a breast out of that. Even nipple can be reconstructed. So the breast cancer patient will feel psychologically very near to normal, so that they can lead a normal quality of life. So breast surgery, say, one need not be afraid. Try to come early so that your breast can be saved. Even if your breast cannot be saved, there are various options to reconstruct your breast so that you feel normal and you can very well be integrated into the society. You can go back to work, you can have a good social life despite suffering from breast cancer, and you have a long duration of life. So every woman has a right to play with their grandchildren, and that is only possible if you come early. So breast cancer, if you come early, you can live up to be a grandmother and play with your grandchildren. Surgery is very safe, anesthesia is very safe. Surgery is standardized throughout the country, and our associations like the ABSI and the Surgical Oncology, Indian Association of Surgical Oncology, they have taken a lead. So the treatment has become very, very standardized. The training is there. Young surgeons are coming out in different parts of the country, and I'm proud that in India, a vast network of surgeons are available who are performing and delivering excellent world-class care for these breast cancer patients. So please come to the hospital, get yourself investigated and treated, and you will go back with a high level of satisfaction after being treated. Thank you. Over to you.
Thank you, sir. So, as sir mentioned, we do have world-class care in both government and private setup, and in terms of surgery, chemotherapy. So now I'd like to ask Mrs. Vandana that, as you have mentioned some points, but how accessible is this care for diagnosis and treatment available to all over India, and what interventions can be taken by the government, the central and state governments, the NGOs, the corporate hospitals, the government hospitals to promote this to the next level?
As of now, I think with our regional cancer centers and the other hospitals that have come up all across the country, there are lots of hospitals which are in all the categories: the government, the semi-government, the private, the corporate hospital, which are available. But unfortunately, people are not aware of the facilities which are there. So if a lot of promotion is done about the various centers which are there where people can go, I think it will make a lot of difference. Especially now in COVID, we have seen that digital health and telemedicine has become the norm of the day. A lot of people are consulting on that. So even through telemedicine, if we can talk about it, if we can give them the idea of which hospital which is nearest to them, they can reach there. Because often people don't like to come to a far off place because of the language problem that they may have, because of the difficulty in traveling, the difficulty in staying, difficulty in leaving their jobs and family behind. So if they can be told about the centers which are nearby, then it can be made easy for them. And one thing which I always keep saying and talking about is that, if each medical center, whether it's a small hospital or a big hospital, wherever it is, and there's a gynecologist to whom the woman is going. And if we could put like a picture there about how to self check your breast, and also what are the options available nearby. So you are telling people how to go about it without making that extra effort of sitting down and informing patients about the various things that they can do. I think that becomes a very, very important thing, because if everybody has to rush to, say, Delhi or to Lucknow or to Bombay for their treatment, obviously there's going to be a huge waiting list, and there's going to be a huge expense which is not related to the treatment, which is going to be different. So to cut down on that cost, because cost becomes an extremely important factor in our in our treatment issues. So if we can cut down on that cost, and I feel that most of the centers are absolutely world class. There's no it's not like people, the good doctors are not there. It's just that people don't know about it, and people are not encouraged to go there. Even if they come to the main hospital, suppose somebody comes to say Tata Memorial Hospital, the doctors in Tata Memorial Hospital can guide them to go to the nearest hospital near their house. It will become like affirmation that because the patient will feel, हाँ डॉक्टर साहब ने बताया तो ये ज़रूर अच्छा होगा. So they would like to go there. Similarly, if there is an NGO who can guide a patient on various things. Even if the doctors can tell them that, we know of this NGO who can guide you into various things, it becomes an affirmation to the patient from the doctor that this NGO can be trusted. So those, we all need to work in collaboration. We all need to work. I know there are too many patients and too little time that everybody has with the patients, but it is, I think, a bonding that has to come from the doctors and from the patients and the NGOs working together to keeping the patient in the focus and then giving the best to the patient. I
True.
don't know whether it makes sense.
No, it does. So, as very rightly said, I think it has to be a combined effort from all of us. And I think even though we all know that early detection is important, screening is important, we do have all treatments available, but for the patient to reach that level of treatment is also important. So I think that brings us to the end of this session. We do have a few questions from the audience. I think we have answered most of them. Like, how do we spread awareness in rural and remote areas? Vandana ji did talk about it. And so there is a question about, is there any correlation between breast cancer and patients suffering or recovering from COVID? Have both of you noticed any such any difference in patients who had COVID during breast cancer treatments?
Uh,
So
I can take that. Not
Yes.
really. There is no difference between that. The only difference, and I will take this platform to educate everyone. We did a study of around 700 people of cancer and COVID, out of which 500 had, 500 had not taken vaccines and 200 had taken vaccines. The only difference in mortality depended upon whether a person was vaccinated or not. People who have got COVID vaccine, even if they have got cancer, have got reasonably no chances of hospitalization or death. People who did not take vaccines were the one who were actually getting admitted in ICUs and were actually unfortunate time. So cancer and COVID, no worries. Vaccine and COVID, please take vaccine.
I think for during the second wave, a lot of our patients refused to come for chemotherapy because they were scared to come to the hospitals for that. That did affect a little bit, but otherwise, yeah, as you rightly said, vaccination should be very important, especially for cancer patients. Okay, there's another question on how valid or accurate are the breast self examinations that we advise women to do at home. So I think Dr. Agarwal can take that question.
Yeah, I think you've already pointed out that it can't be used as an effective screening procedure as compared to mammography. But breast self-examination we use for patients who are already treated for breast cancer. For contralateral breast cancer, they can do a breast self-examination. But yes, in a family, if there's a breast cancer, the family members who are likely, women, they can do a breast self-examination, but it is not a replacement for a mammography. One should understand. Yeah.
So, if a woman has, if there's a family history of breast cancer, should she start screening like how much before the age of the index days? Like, as
I think it's usually 10 years earlier than the.
and if she's young, she should go for an MRI or a mammography, or
See,
both.
MRI is not widely available, and interpretation is an issue. You can get an MRI, but interpreting it is often a problem. And sometimes MRI may pick up more breast cancer, which are false positive if not interpreted properly. So MRI is not really the best way to, but mammography and other things can probably take care of that.
Thank you, sir. So I have another question. Are there any technical innovations happening in the area of detection for breast cancer? So you did mention a little bit about the mobile phone detecting through a bra. Is there any other technological innovation in going?
Thermography is innovation that is taking place. Uh, uh, these are the only thing to my mind. Yeah.
So, thank you so much, all of you, for this very enlightening discussion. And any last words from all of you? It'll be really great to know.
So I will start, and I will start. I will end where I started. Breast cancer October should not be the only breast cancer awareness month. every day, every week, every month. We should be counseling. And I like the way what Vandana ji said. We just say women. All women are somebody's mother, somebody's wife, somebody's sister, somebody's daughter. We would want to take that into confidence, and we would want to remind everyone that women is the most important part of any family. If she falls ill, we will probably have more to pay as men. I'm being very honest about it. So take care of the health. But even if you get, so prevention is the best thing. But even if you get cancer, don't worry. Cancer is just a word. It is not a sentence. It is definitely not a death sentence. And that's my message for everyone. And thank you again.
Thank you, sir.
So,
So,
thank you. I echo what Dr. Batra said. I think breast cancer should be treated as an event which is like a speed breaker in your life, and you have to just go slow. That's all. As you go slow on a speed breaker, but once you cross the speed breaker, life is again back to normal. So, I will just echo: detect to protect. Thank you
thank
for
you.
having me, and I really enjoyed interacting with you all.
Great, sir.
So, as a cancer patient, my last thoughts would be that, one is that we can't keep saying be positive, because what you don't know the circumstances of the person, and to keep saying that be positive does not help. I can say that I can be positive now, not because of being positive, but because I can realize what I did before I had cancer and what I can do now after I had cancer. So that statement of be positive is something which should be really removed from everybody's dictionary to talk to a cancer patient. Secondly, like I said, talking in simple language is the most important thing, and explaining to them. And also, the biggest thing is removing the stigma from the disease, because if the stigma is removed, then people will come forward. Because, and also, giving them information. Like today, I met a lady who has had a mastectomy but has not even been told about a artificial breast, or that she could get a prosthesis. And she was covering all over like this, and she was sitting, and I was like, why are you doing that? She said, I feel a little conscious because my breast has been removed. And then I began to talk to her about processes. So I would really request all our doctors to spend 2 minutes or 5 minutes taking care of these factors, which are the emotional factors for a woman. She can't talk to anybody about it, and nobody can guide her unless there's a very active and robust support group in your hospital. So I think, again, collaborate, doctors. We are here to help you, and we want to work together, keeping the patient as our focus. Thank you.
Thank you so much, Vandana ji, and thank you so much, Professor Agarwal and Dr. Batra. It was really great hearing from all of you, and I also thank Voice of Health for having this discussion. And I hope we've been successful in spreading some awareness and a little more information about breast cancer. And thank you so much again. And let's hope that we keep this such discussions going on, and there is more benefit from all of this, and we actually reach out to all the entire country and improve our early detection rates. And as you said, detect to protect. Thank you.
Thank you. Thank you.